Hi everybody, and welcome to our module on pericardial disease. The pericardium is the sac that surrounds the heart, and there are basically three disorders that affect the pericardium that you should know for your rotations and for your exam. Those three disorders are pericarditis, pericardial effusion and tamponade, and constrictive pericarditis. We'll go through all of them in this module now. Acute pericarditis is the most common pericardial disorder, and as the name implies, acute pericarditis is inflammation of the pericardium. We'll talk about the symptoms and the treatment in a minute, but you should be aware that for some patients, after the symptoms go away, they can recur. So a number of patients require chronic therapy because of recurrent episodes of acute pericarditis. The dominant clinical feature of acute pericarditis is chest pain, and there is a classic way that the chest pain of pericarditis presents, and you need to be able to recognize this clinically and in board questions. Classically, the pain of pericarditis will be sharp. It will be worse with a deep breath, and chest pain that's worse with a deep breath is called pleuritic chest pain. The pain gets worse when patients lie flat and assume a supine position, and it gets better when patients sit up and lean forward. Because this is an inflammatory process, many patients also have fever, they can have a leukocytosis, and the erythrocyte sedimentation rate can also be elevated. And then finally, about 50% of patients with pericarditis will have fluid leak and accumulate in the pericardial cavity, and that will lead to a pericardial effusion. And this has importance, which we'll talk about in a minute, for diagnosis and workup. Patients with pericarditis need to be checked for a pericardial effusion. And this is an echocardiogram on the screen of a patient with a pericardial effusion. This is the heart here, and this black space surrounding the heart is fluid, and that's evidence of a pericardial effusion. There are a couple of classic EKG findings associated with pericarditis, and they're all shown in this example on the screen here. First of all, if we look at lead V2, this is the baseline, and this is the ST segment up in the air. So the ST segment is elevated in lead V2. You can also see ST segment elevations in V3, V4, V5, and V6. You can also see them over here in lead 2. You can see them in lead 1. So what we've got here are diffuse ST elevations. These don't fit with any single anatomic area like the inferior wall, the anterior wall. There are diffuse ST elevations, and that's one of the hallmarks of pericarditis. And I've zoomed in on a lead here so I can show you. These are the ST elevations right here. You can see them in all the QRS complexes of this lead. And then the second important finding of pericarditis on EKGs is called PR depression. If you look at this PR segment, you can note that it kind of goes down at an angle like this. I've sort of drawn an arrow here. Normally the PR segment is completely flat and doesn't angle downward like this. So this is referred to as PR depression. So the two classic findings of pericarditis on the EKG are diffuse ST elevation and PR depression. On physical exam, patients with pericarditis can have a sound called a pericardial friction rub. Not all patients have this, but some of them do. It's a scratchy sound often described as sandpaper rubbing together, and it's present in both systole and diastole because in all phases of the cardiac cycle, the pericardium, which is inflamed, is rubbing against other structures, and that's causing the pericardial friction rub. And I'll play you an example of this now. Pericarditis is a clinical diagnosis. There's no lab test or biopsy finding that makes the diagnosis. And in order to make a clinical diagnosis of pericarditis, you need to have 2 of 4 criteria. The 4 criteria are typical pericarditis chest pain, like we talked about a few slides ago, presence of a pericardial friction rub, the pericarditis EKG changes like ST elevation diffusely and PR depression, and the 4th criteria is a pericardial effusion. And this brings me to an important point that you need to know for your board exams. All patients who have pericarditis need a transthoracic echocardiogram. That's because, like I told you before, about 50% have an effusion, and sometimes those effusions can get very large and cause tamponade, which we'll talk about later. So you always need to evaluate these patients for the presence of a pericardial effusion. Most cases of pericarditis are idiopathic, and we don't identify any single underlying cause or trigger. Another very common cause is viral. There are many viruses that can cause pericarditis, but the classic one is Coxsackie virus. And in many cases, viral pericarditis follows a viral upper respiratory infection. So a classic history to know clinically and for board exams is a patient who has a sore throat or a runny nose, and then a few days or weeks later develops pericarditis. That is a fairly classic presentation of viral pericarditis. Rarely, bacteria and fungi can cause pericarditis. Bacteria often spread from pneumonia, or they're introduced into the pericardium as a complication of surgery. And then in very rare cases, tuberculosis can spread and cause pericarditis. Patients who are uremic from renal failure can develop pericarditis, and just as an aside here, the treatment for this is hemodialysis that will resolve the pericarditis. If you're shown a board question of a uremic patient with pericarditis, do not choose drugs as the answer. You need to send that patient for dialysis. There are a couple of ways that patients can develop pericarditis following a myocardial infarction. A few days after a myocardial infarction, patients can develop what's known as fibrinous pericarditis. This is where the inflammatory cells of the infarction travel and cause inflammation of the pericardium. And then a few weeks after myocardial infarction, patients can develop an autoimmune reaction called Dressler syndrome, where they develop pericarditis. And I talk about these things in the video on myocardial infarction. And then finally, patients who have certain autoimmune diseases, especially rheumatoid arthritis and lupus, can have an autoimmune attack of the pericardium and develop pericarditis as a complication of their autoimmune disease. There are 3 treatments that are used for acute pericarditis. The first one is non-steroidal anti-inflammatory drugs. Usually naproxen or sometimes ibuprofen is prescribed regularly for usually several months, and this will suppress the inflammation of pericarditis. In patients who can't take NSAIDs, possibly because of gastritis or because of kidney disease, glucocorticoids can be used as a second-line option. And then finally, colchicine is a unique drug. It inhibits white blood cells via a complex mechanism, and it's really only used in a couple of niche circumstances. It's useful in gout, it's useful in the rare condition familial Mediterranean fever, and then its third use is in pericarditis. And there have been studies that have shown that if you add colchicine to NSAIDs, you lower the risk of recurrence of acute pericarditis when treating patients with pericarditis. So for most cases that you will see of pericarditis, the treatment that will be prescribed will be NSAIDs plus colchicine, usually for a couple of months, and then the drugs can be stopped. And in most cases, that will lead to complete remission. In a minority of cases, the pericarditis may return. Let me mention one special caveat on the treatment of pericarditis that occurs post-myocardial infarction. There's 2 ways that this can happen, as I mentioned earlier. Fibrinous pericarditis presents within a week of a myocardial infarction, and this is caused by inflammation from the infarction extending into the pericardium. The other way you can get post-infarction pericarditis is from Dressler syndrome. This presents weeks after a myocardial infarction, and this is an autoimmune process. Now, Dressler syndrome is treated with NSAIDs and colchicine and the usual drugs that we use to treat pericarditis. But fibrinous pericarditis has a special therapy. Usually these patients are getting aspirin for their myocardial infarction, and that's usually all that's given. Sometimes Tylenol is added for pain control, and if you do these things, fibrinous pericarditis usually resolves on its own within a few days. Importantly, however, and this is high yield to note for your boards, NSAIDs are avoided in fibrinous pericarditis. There's little evidence of benefit for NSAIDs in this condition, and there's some evidence of harm that they can worsen the outcomes from the infarction. So in a patient with fibrinous pericarditis, that patient should get aspirin for their MI, but they should not be given other NSAIDs because they can potentially be harmful. Moving on, let's talk about pericardial effusion and pericardial tamponade, which are closely related problems. A pericardial effusion refers to fluid in the pericardial space. If you look at this drawing shown on the screen, on the left is a normal heart with a normal pericardial space, and there's always a little bit of fluid in the pericardial sac surrounding the heart. On the right is an example of a pericardial effusion. Lots of fluid has accumulated in the pericardial sac, and that is called a pericardial effusion. Now, most patients who have pericardial effusion are asymptomatic, but if the amount of fluid and the pressure of the fluid surrounding the heart gets high enough, it can cause the clinical syndrome of pericardial tamponade. So pericardial tamponade is a consequence of a pericardial effusion. If the pressure in the fluid surrounding the heart gets high enough, then the ventricles can't fill in diastole. Remember, in diastole, the ventricles need to relax and open up to allow blood to fill. But if they're surrounded by fluid in the pericardial sac that has a very high pressure, then the ventricles can't relax and fill, and therefore you essentially get a variant of heart failure with poor filling of the right and left ventricle and potentially low cardiac output. The amount of fluid that needs to be present in a pericardial effusion to cause tamponade varies based on the time frame over which that fluid accumulates. If the fluid accumulation is acute from something like bleeding, then just a very small amount of fluid is required to cause the clinical syndrome of tamponade. On the other hand, patients who have cancer metastasis to the pericardium have a slow, chronic accumulation of pericardial fluid. These patients can have a very large pericardial effusion before they develop tamponade because their body has time to adapt to the presence of that fluid. So here's another echocardiogram image of a patient with a pericardial effusion. This black area here is evidence of fluid around the heart. This is the wall of the left ventricle, which is right here. The right ventricle is here. There's also a little bit of fluid around the front of the heart. Anytime you see a black stripe surrounding myocardium in an echocardiogram image, you should be concerned that that may be showing you a pericardial effusion. And this is the water bottle sign on chest x-ray. You can see that the heart takes on this sort of circular globular water bottle shape. That is also evidence of a pericardial effusion. But remember, this only means the patient has a pericardial effusion. This doesn't mean they have tamponade. Tamponade is a clinical diagnosis, which we'll talk about in a minute. An echocardiogram showing fluid around the heart or the water bottle sign on chest x-ray only tell you that the patient has an effusion. So let's talk about the clinical features of tamponade. First of all, the heart sounds are distant. That's because of that fluid surrounding the heart. It makes it harder for you to hear the S1 and the S2 of the heart sounds. Dyspnea is a hallmark feature of pericardial tamponade. And interestingly, in tamponade, dyspnea occurs in absence of pulmonary edema. So a patient who is short of breath with distant heart sounds, but on clinical exam you do not hear crackles of pulmonary edema, that strongly suggests pericardial tamponade. The reason that dyspnea occurs in tamponade is incompletely understood. And then finally, the jugular venous pressure will go up. That's because the right ventricle can't fill, so the right atrial pressure gets high, and that causes the jugular venous pressure to be high, and you can see this on physical exam. Beck's triad is a triad of clinical findings seen in tamponade. The three clinical findings of Beck's triad are distant heart sounds, elevated jugular venous pressure, and these two we just talked about in the last slide, and the third criteria is hypotension. And this is seen only in rapidly developing traumatic effusions. If you have a rapidly developing effusion, like from bleeding after trauma, that can cause so much underfilling in the left ventricle that it can cause hypotension. So these patients have a very low cardiac output because the right and left ventricles aren't filling. There's low preload on the left ventricle and therefore low cardiac output. In slower effusions, like those that accumulate in cancer patients, the pericardium stretches and dilates, and you usually do not get hypotension. So Beck's triad in the presence of hypotension is something you will only see in traumatic effusions. It's not something you'll see in other patients with slowly accumulating effusions. Let's talk about pulsus paradoxus. This is the classic finding in tamponade. If pulsus paradoxus is present and there's a pericardial effusion, that patient certainly has tamponade. To understand pulsus paradoxus, you need to understand that your systolic blood pressure always falls slightly when you inspire. So if we could measure your blood pressure while you're breathing normally, when you take in a breath of air, the systolic pressure will fall a few millimeters, and when you exhale, it will go up a few millimeters. In patients who have pericardial effusions and tamponade, this becomes exaggerated, and the fall in blood pressure with inspiration can get over 10 millimeters of mercury. That's the definition of pulsus paradoxus. And the reason this finding was named pulsus paradoxus is because years ago, when examining patients who had very, very large effusions and severe tamponade, the fall in blood pressure was so great that the pulse disappeared. So these patients, like 100 years ago, when there was no treatment for pericardial effusions and tamponade, they would have a pulse that would come and go as they took in a breath of air, and that's why it was called pulsus paradoxus. In the modern era, we almost never see that, but you will see an exaggerated fall, and that is evidence of pulsus paradoxus. For your board exams, it's high yield to know that you can also get a pulsus paradoxus in patients with asthma and COPD. This is because inspiration of air normally decreases blood flow to the left side of the heart, and this decrease gets exaggerated in lung disease. So in a board question of a patient with an asthma or COPD exacerbation who has a exaggerated fall in their blood pressure, that patient may not have tamponade. In clinical practice, we only measure pulsus paradoxus in patients who we know have effusions and possible tamponade, so usually this is not a big issue. There's a classic EKG finding seen in some patients with tamponade. It's called electrical alternans. If you look at this EKG on the screen, you can see we've got a big QRS complex and then a small one, and then a big one and a small one. This is called electrical alternans. And what's happening is the heart is swinging inside that fluid sac in the heart, and sometimes it depolarizes when it's in one position in the sac, and sometimes it depolarizes when it's in a different position in the sac, and that causes the QRS complexes to go back and forth as the heart swings inside that fluid-filled sac. This is only seen in very large pericardial effusions. Tamponade is almost always present. These patients usually also have sinus tachycardia, and usually the voltage is low, and that's because there's an effusion, and therefore it causes the EKG voltage to be lower than normal. The voltage is the height of the QRS complex. The voltage will be low in any cause of pericardial effusion, and it's also low in electrical alternans. The diagnosis of cardiac tamponade requires clinical evidence of tamponade, so you need to identify a pulsus paradoxus to show that there's hemodynamic consequence of an effusion, and then you also need a transthoracic echocardiogram to show that an effusion is present. The treatment is to give intravenous fluids. This is because these patients are what's known as preload dependent. They need lots of fluid filling their ventricles because the ventricle is struggling to fill due to the pericardial effusion. So you want to load their body up with intravenous fluids. The worst thing you can do for these patients is give diuretics. And in a board question of a patient who's short of breath with tamponade, do not choose to give diuretics. That can cause hypotension and cardiac arrest. So intravenous fluids can be given temporarily to stabilize the patient, and then the ultimate treatment is to remove the fluid around the heart. This can be done by inserting a needle into the pericardial space. This is called pericardiocentesis. And then also you can do this by having the patient go for surgery, and a hole is cut in the pericardium. This is called a pericardial window. And once this is done, fluid can no longer accumulate in the pericardial space. A right heart catheterization can be done to make a diagnosis of tamponade. This isn't often done because right heart catheterization is invasive. But when it is done, what right heart catheterization allows you to do is measure the pressure in the right atrium, the right ventricle, the pulmonary capillary wedge pressure, and the left ventricular pressure. And if you do this in patients with tamponade, the classic finding is known as equalization of pressures. Let's take a look at this table on the screen. I've shown normal pressures for the right atrium, right ventricle, wedge pressure, and left ventricular end diastolic pressure in the first column. When patients develop tamponade or constriction, we'll talk about pericardial constriction in a minute, but when they develop either of these disorders, they get equalization of pressures. What that means is the right atrial mean pressure becomes equal to the right ventricular end diastolic pressure, which is also equal to the wedge pressure and the left ventricular end diastolic pressure. Normally, the pressures should not all be equal here. The reason they're all equal in tamponade is because the pressures are being determined by the pressure in the pericardium. So this example on the screen, the patient's pericardial pressure is 20, and therefore the pressure in all those chambers becomes equal to 20, and that's equalization of pressures. This occurs when the cardiac chambers cannot relax normally, and it's seen in tamponade and also pericardial constriction. I've summarized a few of the causes of pericardial effusions and tamponade on this slide. We already talked about how about half of patients with pericarditis develop an effusion, and some of those patients can have the effusion get so large it causes tamponade. Cancer patients often have metastases to the pericardium, and this can cause an effusion in tamponade. And then finally, trauma can cause those rapidly accumulating effusions, which can lead to Beck's triad and tamponade. And then our final pericardial disorder is constrictive pericarditis. This is very rare. In 12 years of practicing cardiology, I've only seen it twice. So let's talk about it now. You just need to know enough to answer board questions. If you look at this CT scan on the screen, this is the left ventricle of the heart here, and this is the right ventricle. And you can see this white stuff surrounding the ventricles. That is calcium in the pericardium, and that's what you see in constrictive pericarditis. The cause is calcification of the pericardium due to long-standing inflammation. So constrictive pericarditis occurs when there is fibrous tissue and calcified scar tissue present in the pericardium. It causes the pericardium to lose its elasticity. It becomes stiff and thickened and sticky. And it can result from any pericardial disease process. Usually it's from patients who've had multiple episodes of pericarditis, but you can also see it in patients who've had radiation to the chest that has caused inflammation of the pericardium. You can also see it in patients who've had heart surgery where the pericardium was incised or damaged during the operation. But any of these processes lead to inflammation, and if the inflammation goes on long enough, that leads to scar tissue forming in the pericardium. So to understand the clinical features of constrictive pericarditis, you need to appreciate that the major problem here is that the ventricles can't fill. The ventricles fill with blood, but it abruptly stops because the pericardium cannot stretch. So this is similar to the physiology of tamponade, but for a different reason. In tamponade, there's a high pressure fluid collection surrounding the ventricles. In constrictive pericarditis, there's a calcified, stiff pericardium surrounding the ventricles. The hallmark feature is dyspnea. Patients always complain of dyspnea, and this is from a low cardiac output. And then the second thing to know for your board exams is patients with constrictive pericarditis have very prominent features of right heart failure. The constriction really affects the ability of the right ventricle to fill. So these patients can have very high jugular venous pressure on exam. They can have lots of lower extremity edema. Their liver can become congested, and if the congestion goes on long enough, it can lead to cirrhosis. This is referred to as a nutmeg liver. This is a picture of one on the screen here. These dark spots are evidence of the nutmeg liver, which is what you can see in long-standing right heart failure from any cause, but classically from constrictive pericarditis. Other features are shown on this slide. You can have a pulsus paradoxus, but it's very uncommon. Only about 20% of patients have this. A pulsus paradoxus is really a classic sign of tamponade. The pressures in all the cardiac chambers can get high. That's because the chambers aren't filling well. The pressures can become equalized, like we talked about earlier. And then finally, in a minority of patients, there is a heart sound called a pericardial knock. This is a diastolic sound that occurs shortly after S2, similar to an S3, and it sounds like someone knocking on a door. Although pulsus paradoxus is rare in constrictive pericarditis, there is another physical exam finding called Kussmaul's sign that is a classic finding in patients who have constrictive pericarditis. To understand Kussmaul's sign, you need to appreciate that when you're breathing normally and you inspire, there's a slight increase in the venous return to the right ventricle. This leads to a slight fall in the mean jugular venous pressure. So if you're examining a patient at a 45-degree angle like this, to measure the jugular venous pressure, you find the double bounce caused by the A and the V waves of the venous pressure tracing. When you see that double bounce, that tells you what the jugular venous pressure is. And when the patient takes in a breath of air, under normal circumstances, that double bounce will fall slightly. And that's because the venous pressure is falling slightly like shown here on the screen. Kussmaul's sign refers to a situation where the jugular venous pressure does the opposite of what is normal and it goes up with inspiration. This happens anytime the right ventricle cannot accept the increase in venous return associated with inspiration. So since that blood cannot go into the right ventricle, the jugular venous pressure shoots up instead of falling like it should. This is a classic finding in constrictive pericarditis. It's also a classic finding in two other conditions. The first is restrictive cardiomyopathy. The second is a right ventricular myocardial infarction. In all three of these disorders, jugular venous pressure goes up with inspiration. That is called Kussmaul's sign, and that is because the right ventricle cannot fill and accept that increase in venous return. So they love to ask you about pulsus paradoxus and Kussmaul's sign on your board exams, and when I was in training, it was always hard to keep these straight. They're very rare clinically, so you just have to memorize the situations in which they occur. So here's my little trick for remembering this. Pulsus paradoxus is a classic sign of tamponade, and you can just remember that pulsus is seen in tamponade with the P. Kussmaul's sign, on the other hand, is a classic sign of pericardial constriction. It's also seen in restrictive heart disease, so you can remember that Kussmaul's occurs in constriction and restriction. This is my own little trick here. Use it if you wish. And at the bottom is a table showing you that in tamponade you get pulsus, but you don't get Kussmaul's. In constrictive pericarditis, you get Kussmaul's, but usually not tamponade. And in restrictive cardiomyopathy, which I talk about in another video, you usually don't get pulsus, but you can also get Kussmaul's. The diagnosis of constrictive pericarditis can be challenging, and often the diagnosis is made from findings from a number of different tests. But let's go through some of the different tests and talk about what they can show. First of all, you should know that the ECG is usually not helpful. It has only nonspecific findings in most cases. Sometimes a diagnosis can actually be suggested by chest X-ray, which can show calcifications in the pericardium. If you look at this X-ray on the screen, these are calcifications in the pericardium here. That's the bright white surrounding the heart. And if you see that in a patient with symptoms of constrictive pericarditis, that can help make the diagnosis. Echocardiography is the standard first test to do when you think a patient may have constrictive pericarditis. Unfortunately, one thing to know about cardiac echo is that it doesn't visualize the pericardium very well, so you don't get a good look at this to make the diagnosis. Usually what you see is a normal left ventricular ejection fraction. There can be enlarged atria from high pressures within the chambers of the heart, and then you can measure the filling velocities of the different chambers of the heart. This is an advanced topic, but these are often abnormal, and that suggests a diagnosis of constrictive pericarditis. In many cases, the findings on echo aren't enough to make the diagnosis, so there are findings on both cardiac MRI and CT that patients with constriction can have, and then there are also hemodynamic findings in the cardiac catheterization laboratory. And so usually the diagnosis is made with clinical features plus echocardiography plus supporting evidence from some of these other testing modalities. And the treatment is with surgical pericardiectomy to remove the pericardium and remove the constriction around the heart. And that concludes our module on constrictive pericarditis.